Concept 26, Mobility. After completing this lecture, you'll be able to define and describe mobility. Notice risk factors for impaired mobility, recognize when an individual has compromised mobility, provide appropriate nursing and collaborative interventions to optimize mobility and minimize complications of immobility. Mobility refers to purposeful physical movement, including gross, simple movements, fine, complex movements, and coordination. Mobility is dependent on the synchronized efforts of the musculoskeletal and nervous systems, as well as adequate oxygenation, perfusion, and cognition. Specifically, mobility requires adequate energy, adequate muscle strength, underlying skeletal stability, joint function, and neuromuscular coordination to carry out the desired movement. For the purposes of this concept analysis, mobility is defined as a state or quality of being mobile or movable. There are many variations on the term mobility seen throughout the literature worth mentioning. The term immobility refers to an inability to move. Impaired physical mobility describes a state in which a person has a limitation in physical movement, but is not immobile. Although immobility is typically considered a negative state, there are times when immobility or immobilization is therapeutic. For example, the immobilization of a shoulder, if it has been dislocated, provides desired rest, recovery, and comfort. The term deconditioned is used to describe a loss of physical fitness. This applies not only to an athlete who fails to maintain an optimal level of training, but also to an individual who does not maintain optimal physical activity. In the context of healthcare, this term applies to the patient who experiences extended immobility, resulting in an overall deconditioned state of the musculoskeletal and cardiopulmonary systems. This is particularly a problem among older adults. Another similar term is the disuse syndrome, first proposed more than 30 years ago by Bortz, describes the predictable adverse effect on body tissues and functions associated with sedentary lifestyle and inactivity. Identifying characteristics of the disuse syndrome, as defined by Bortz, included cardiovascular vulnerability, obesity, musculoskeletal fragility, depression, and premature aging. The scope of mobility as a concept ranges on a continuum from full mobility to partial mobility, as referred to as impaired mobility, and complete immobility. Mobility can be considered on a micro or macro perspective. Mobility and immobility may refer to a particular part of the body, or they can refer to the entire body. Thus, mobility and immobility are not mutually exclusive. For example, a patient with an immobilized extremity can still be mobile. Also, because mobility is on a continuum, a change in mobility may be temporary. Variations in mobility are seen among individuals across the lifespan with multiple causative factors and a wide range of degree of impact and duration. Changes in mobility can be temporary, long-term, or permanent and are influenced by general health status with specific conditions associated with neurologic or musculoskeletal system. Restrictions in mobility may also be indicated following a medical procedure or diagnostic test. An individual's general health status has significant influence on mobility. Many conditions lead to changes in mobility, including acute illness or injury, debilitating chronic conditions, particularly cardiovascular and pulmonary conditions leading to fatigue, and conditions involving end-of-life care. Conditions that specifically lead to mobility impairment include neurologic, musculoskeletal, or combination of both. Conditions in these three categories can be caused by congenital defects, genetic conditions, injuries, inflammation, infection, autoimmune disorders, or neoplasms. Medical procedures and diagnostic tests may require temporary restrictions on mobility to reduce complications. Optimal mobility relies on bones, joints, articular cartilage, tendons, ligaments, skeletal muscles, and the mechanics of muscle contractions. Underlying these functions is an intact neurologic system whereby signals for all movement are communicated to and from the brain through nerve impulses. All movement is coordinated by the brain through a complex process of sensing internal and external data signals, integrating these data signals and responding by triggering motor activity. The motor cortex in the frontal lobe of the brain is responsible for voluntary motor activity through a series of nerve impulses sent from the brain through the spinal cord and peripheral nerves to the target muscle. The cerebellum, located at the base of the brain, coordinates movement, equilibrium, muscle tone, and proprioception. The musculoskeletal system. The skeleton has three overreaching roles as related to mobility. It acts as the structural foundation for the body and as leverage to move body parts, supports and protects tissues and internal organs, and provides attachment sites for muscles and ligaments. Bones also serve as a storage center for calcium and as a production center for red blood cells within the bone marrow. The human body has 206 bones classified into two groups, the axial skeleton and the appendicular skeleton. All structures designed for use over time require ongoing maintenance and intermittent repair. The same is true for the skeletal system. Remodeling is a term that describes an ongoing maintenance of bone tissue through a process in which new bone tissues replace existing bone tissue in bone remodeling units. The remodeling process also provides the mechanism to repair injured bones. Remodeling requires adequate nutrition, hormone regulation, and blood supply. The severity of the bone injury and the availability of remodeling elements influence the rate or speed at which injured bone heals. Joints. Bones come together at joints. Joints provide stability to bones and allow skeletal movement. Mobility is impacted by the degree of joint freedom. Joints allow for skeletal positioning to carry out the desired action. The various types of movement provided by joints include flexion, extension, rotation, adduction, abduction, supination, and pronation. Some of the most common problems associated with the mobility arise as a result of joint pain and/or changes in the joint function. Three classifications of joints include sinoarthros joints, amphithorosis joints, and diarthrosis joints. Joints are classified by structure. Fibrous joints serve to hold bones together in place with connective tissue. Cartilaginous joints feature cartilage material that hold the joint together and provide some movement. Joints that allow the most movement are those also the most complex. Synovial joints have multiple elements, including a joint capsule, synovial membrane, joint cavity, synovial fluid, and articular cartilage. Articular cartilage acts as a cushion by distributing joint loads over a wide area, thereby reducing prolonged compression of articulating bones within the joint. Without cartilage, significant friction and pain result from the joint movement. Muscles. Skeletal muscles differ from other types of muscle in the body in many ways, but one of the most important differences is that it's under voluntary control. Optimal skeletal muscle function depends on the following 5 factors: nerve impulses, reaching the muscle fibers' response to the nerve stimulus, proprioception, mechanical load, and joint mobility. Impairment of any one of these factors negatively impacts purposeful movement. Nerve impulses reach skeletal muscles from the spinal cord and peripheral nerves via motor neurons. The motor neurons innervate a group of muscle fibers known as the motor or muscle unit. There are many different types of muscle fibers within a muscle unit depending on the function and type of responsiveness required. Muscles that maintain body posture do not have the same need for quick responsiveness as do ocular muscles, for example, but are less sensitive to fatigue. Muscle movement occurs in response to nerve stimulation of the muscle fibers, triggering muscle contraction. On a cellular level, the functional units of the muscle contractions are myofibrils. Movement occurs in a reciprocal manner among the muscle groups. If one group contracts, another group must relax. Proprioception is the mechanism that provides a sense of position and movement. This process allows for accuracy in the degree of movement with muscle contraction. Mechanical load of movement is associated with having adequate strength within the muscle group to carry out a desired task. For example, most humans would struggle to pick up a 250-pound object and walk 50 feet with it. However, such a feat is possible for individuals who are well conditioned for this. Significant changes to the musculoskeletal system occur throughout infancy and childhood as a function of growth and development. The appendicular skeleton grows faster than the axial skeleton, partly because the appendicular skeleton is disproportionately shorter than the axial skeleton. Throughout infancy, childhood, and adolescence, bones change in composition, grow in length and diameter, and undergo changes in rotation and alignment. Similarly, the size and composition of muscles undergo changes as a result of physical growth and development throughout childhood, and they are a major factor in weight gain during adolescence. A number of musculoskeletal changes occur with aging. In the spinal column, a thinning of vertebral disc, shortening of the spinal column, and an onset of kyphosis with the spinal column compression occur. Bone density decreases and bones become brittle, particularly in females, leaving older adults more susceptible to fracture. Cartilage becomes rigid and fragile, and there is a loss of resiliency and elasticity of ligaments. Muscle mass and tone reduce significantly in the late adult years. Cumulatively, these changes result in mobility impairment attributable to reduced range of motion and pain in joints, reduced muscle strength, and an increased risk for bone fracture. Attaining and/or maintaining mobility is paramount to health. The human body was designed to move, thus when movement is limited, consequences occur. The degree of consequences is largely dependent on the degree of mobility impairment and length of time impairment exists. As a general rule, the greater the extent and length of time, the greater the physiological consequences. A state of complete immobility has a significant impact on the entire body. Literally, all systems are affected. Now let's talk about kind of each system separate. So cardiovascular complications occur both with central and with peripheral perfusion. A lack of physical activity results in reduced cardiac capacity. According to one study, a 15% reduction in muscle mass will occur after 12 weeks of complete immobility. This translates to reduced force of cardiac contraction and a reduction in cardiac output. The loss of endurance and the deconditioned state present challenges when the resumption of physical activity is desired. Problems also occur with the vascular system. Decreased efficiency of orthostatic neurovascular reflexes and diminished vasopressor mechanisms cause orthostatic hypertension intolerance when an individual attempts to attain an upright position because of blood pooling in the extremities. Adequate perfusion and venous return depend on skeletal muscle contraction and frequent changes in body position. Because muscular contraction facilitates venous return, venous stasis occurs during periods of inactivity. Slow blood flow provides an opportunity for the formation of blood clots. Deep vein thrombosis is a relatively common complication associated with immobility. Respiratory complications. Physical activity is associated with full lung expansion, particularly among those engaging in exercise. Immobility contributes to reduced lung expansion and eventually leads to atelectasis and reduced capacity for gas exchange. Pooling of respiratory secretions coupled with reduced cough effort places the immobilized patient at risk for stasis pneumonia. Musculoskeletal complications. Muscle tone, joint movement, and maintenance of bone density require active skeletal contraction and weight bearing. Skeletal muscle adapts to non-use by reducing mass. Thus, prolonged immobility leads to significant reduction in muscle mass and atrophy. In fact, an average loss of 25% muscle mass occurs with permanent immobility. The lack of activity leads to contracture in the joint, primarily as a lack of muscle shortening. Muscular atrophy and joint contraction are particularly concerning because together these negatively affect functional ability. The lack of weight bearing leads to bone demineralization and calcium loss from the skeletal system. The degree of bone demineralization and calcium depletion is related to the severity and duration of immobility, as well as the degree of weight-bearing ability. Over time, osteoporosis can develop in response to immobility. Integument system. Sustained pressure on the skin reduces perfusion to the tissues. A reduced flow of oxygenated blood causes hypoxemia of the tissues and increases the risk for skin breakdown. Individuals who lack the ability to move in bed have an increased risk not only because of pressure, but also because of shearing forces that often accompany certain positions or occur during transfers. These problems are further exacerbated if the patient has poor nutritional status and is incontinent. Development of pressure ulcers commonly results. Gastrointestinal complications. Constipation is a frequently reported complication of immobility for several reasons. First, not being able to assume an optimal upright position makes having a bowel movement more challenging. For many people, relying on the assistance of others to have a bowel movement is embarrassing and may lead to reluctance in acting on the urge. From a physiological standpoint, the gastrointestinal tract slows during states of immobility, resulting in reduced peristaltic motility. Constipation, reduced appetite, and anorexia negatively impact nutritional status. Urinary complications. Immobility leads to three common problems that occur within the urinary system: renal calculi, urinary stasis, and infection. Renal calculi result from stasis of urine in the renal pelvis, and because of increased circulating serum calcium levels, the bladder loses tone, making it difficult to completely empty the bladder, particularly in a lying position for voiding. This often results in urinary tract infection because the presence of urinary stasis provides an optimal environment for the growth of bacteria. Psychological effects. Acute and chronic psychological conditions that result from immobility include boredom, depression, feelings of helplessness, hopelessness, grieving, anxiety, anger, disturbed body image, and decreased verbal and non-verbal communication. Individuals who are unable to work or even unable to meet basic activities of daily living often experience a loss of self-worth or value associated with the role change. Social isolation and mood disturbances are common. Psychological effects of immobility are especially concerning among children. For children, physical activity is integral to daily activity. Not only is it essential for physical growth and development, but also it is central to expression, communication, and making sense of the world around them. Immobilization can interfere with intellectual and psychomotor function. Emotional responses range from anger and aggressive behavior to passive, quiet demeanor and withdrawal. Developmental regression is common. Children often become less communicative and may experience depression. In some cases, hallucinations occur. Risk factors. Populations at risk. All individuals are potentially at risk for altered mobility regardless of age, ethnicity, race, or socioeconomic status. Because of the effects of aging, the population group at greatest risk for impaired mobility is older adults. These changes predispose older individuals to a greater incidence of falls and greater challenges regaining full mobility following a period of impaired mobility. An estimated 90% of hip fractures are a result of falling. 76% of hip fractures occur among elderly women. Individual risk factors. Individual risk factors for changes in mobility are often attributed to acute or chronic conditions, chronic pain, and injury or trauma. Specifically, individuals with orthopedic injuries, congenital deformities, neurologic disorders, strokes, head injuries, spinal injuries or deformities, nutritional deficiencies, cardiopulmonary conditions, and end-stage cancer are particularly susceptible. Side effects and adverse effects of many medications and medical treatments can also affect mobility. So when somebody comes in and they have complaints of like impaired mobility or painful joints, we're going to need to do a thorough musculoskeletal assessment. So the history as it relates to the concept of mobility includes general health information such as like past health history, medications and surgeries and treatments, and social history. This will include things like lifestyle, employment, family assessment, and activities of daily living, this will be your starting point. In addition, the history includes an investigative of specific symptoms experienced by the patients. Areas of question specific for mobility include like presence of pain with movement, recent changes in mobility or problems with balance. Do you have any fatigue? Have you had any recent falls? Recent changes in ability to complete any activities of daily living? And then as you proceed with your examination, it'll be objective data regarding the assessment of the musculoskeletal systems, including assessment of gait and body posture, joint size, symmetry, and strength of muscles, and range of muscle of joints. Pediatric assessment also involves observation of motor activities as related to developmental milestones. Expected findings include, the patient should have like an erect posture, symmetry of extremities, gait should be smooth, coordinated, and balanced, the spine should be straight, and expected curvatures, muscles and joints should be assessed for size, symmetry, strength, range of motion, and stability. You're going to compare right and left sides. Findings considered abnormal would include like deformity to the bone and joint, edema, ecchymosis, localized warmth and redness, loss of function, numbness, maybe they're guarding due to pain, and any limitations in movement or mobility. Further information related to conducting an assessment of the musculoskeletal system will be noted and updated to the physician. So many diagnostic tests are used to evaluate musculoskeletal disorders. So an X-ray evaluates the integrity of a bone and joint and is the most common radiographic test used to diagnose fractures. A CT scan used to identify soft tissue and bony abnormalities and evaluate musculoskeletal trauma. An MRI uses radio waves and magnetic fields to provide an image of soft tissue. This is used most efficiently to evaluate soft tissue such as vertebral disc, tumor, ligaments, and cartilage if they've had any injuries to those. A myelogram is a radiographic study of the spinal cord and nerve root using contrast dye. This is particularly useful in evaluating individuals with back pain. An arthrography or an arthrogram is a visualization of a joint by injection of a contrast substance into the joint cavity, allowing for evaluation of bones, cartilage, and ligaments. This is most commonly performed on the knee and shoulder joints, but it can also be done on hips, ankles, and wrists. Bone mineral density is a diagnostic test used to determine the core mineral content and density of the bone. This is used for the diagnosis of osteoporosis or osteopenia. Bone scan evaluates the bone uptake of a radionuclide material. The uptake is related to the metabolism of the bone. The primary indication of this test is to detect metastatic cancer in the bone, but it's also used to evaluate avascular necrosis or unexplained bone pain. Some other diagnostic tests are an arthroscopy is a procedure that allows direct visualization of the interior of the joint through an endoscope. This procedure is most commonly performed on the knee, but it can be done on other joints as well. There's an electromyography, is an evaluation of the electrical activity generated within a muscle. This is used to determine the quality of the neuromuscular innervation. And also there can be lab tests can be used to provide various types of information about the functional state of muscles, bones, or joints. Types of blood tests include like an alkaline phosphatase, calcium, phosphorus, uric acid, creatinine kinase, blood urea nitrogen, creatinine, and myoglobinuria, analysis of joint fluids, and a pathological analysis of biopsy tissue, maybe like a muscle biopsy or a bone biopsy. Clinical management, primary prevention. Regular physical activity is associated with multiple health benefits and is foundational to primary prevention measures. Prevention of problems associated with mobility is relatively simple. That is, maintaining the highest level of regular physical activity possible along with optimal nutrition. Keeping an ideal body weight and getting adequate rest. Taking measures to prevent injury and trauma are also considered primary prevention strategies. Nutrition as a primary prevention strategy links to musculoskeletal development. During infancy, childhood, and adolescence, adequate protein and calcium in the diet are critical for the musculoskeletal development described previously. Adequate calcium intake is also necessary to prevent osteoporosis among older individuals. Maintaining a healthy body weight prevents excessive joint strain and is associated with fewer problems with back pain. Falls represent one of the most common mobility problems among older adults. Thus, fall prevention is an important aspect of primary prevention. Strategies include participating in regular physical activity, making the environment safer, and optimizing vision. Secondary prevention. The primary areas to highlight related to mobility and screening are osteoporosis, mobility screening, and fall risk assessment. For osteoporosis screening, the U.S. Preventative Services Task Force recommends screening of women ages 65 years and older, as well as younger women who have increased fracture risk. Dual energy X-ray absorptiometry of the hip and spine is the recommended method to measure bone density. There is no recommendation for the screening interval. Furthermore, the USPSTF concludes that evidence is insufficient to recommend screening for men. A large number of mobility and fall risk assessment screening tools are available. Scott and colleagues reviewed 38 different fall and mobility assessment tests for use among older adults and concluded that most are reliable. However, they were unable to conclude whether one screening test was better than another because of the wide range of settings for use. One of the most common screening tests is the timed get up and go, which measures mobility in people who are able to walk on their own. Another common screening test is the performance-oriented mobility assessment test, which aids in the identification of gait and balance impairments. Mobility scales, such as Greenville Early Mobility Scale, are used in inpatient settings to track the status and progress of a patient's mobility, thus enhancing the effectiveness of mobility interventions among interdisciplinary teams. Collaborative interventions are also necessary. Many nursing interventions are incorporated into the care for the immobilized patients, regardless of underlying conditions. So progressive mobility refers to the application of a mobility plan involving a series of progressive interventions and activities that include positioning, turning, range of motion exercises, head of bed elevation. So first, the patient should be positioned with appropriate body alignment. This is important to prevent injury to extremities and joints and is critical to prevent pulmonary complications as well. For example, patient pillows are commonly used to support the body alignment for a patient placed in a Sims position. The patient is dependent on caregivers for positioning, is at a significant risk for skin breakdown because of prolonged pressure over bony prominences. So skin care is a priority for immobilized patients. The skin should be kept clean and dry and protected to prevent skin breakdown. The skin is regularly monitored and examined for evidence of adequate circulation. Because immobilized patients are at risk for stasis pneumonia, coughing and deep breathing are part of a standard treatment plan. So patients with adequate cognition are encouraged to use the incentive spirometer every hour to maintain ventilator capacity. For patients who are unable, they have a CLRT bed, and this bed is a continuous lateral rotation therapy, so it kind of turns them into different from like side to side. You can also put them in prone position to help with moving the pulmonary secretions. There's also bed exercises should be encouraged to the extent possible to minimize atrophy and maintain joint movement. Many types of exercises can be done. There can be like range of motion exercises that the patient can do while they're in bed. If they're unable to do themselves, we can do like active range of motion is performed by the patient, or there's assisted range of motion involves the patient doing most of the exercises, but under the guidance of a healthcare, or there's passive range of motion, where involves the nurse taking each effective joint through the full range of motion. So it's important, though, remember not to force the joints past the point of resistance, and if tolerated, patients should be encouraged to stand at the side of the bed to promote weight bearing. I always say it's important. I kind of have this rule, like everybody gets up for every meal. In the morning, when you're in bed, what's the first thing you do? You get up, you go to the restroom, you might brush your teeth, things like that. So I kind of have this little thing I do. I know it gets time consuming, but I bring everybody like a warm little cloth, kind of wipe your face off. I try to get everybody to, brush their teeth, because those are the same things we do at home. So, and then I get, with my CNA and stuff, we get everybody up for breakfast. Even if we can't physically get everybody up to a bedside chair, in the acute setting, we're lucky enough to have that the beds, on most of the floors I worked on, the beds went to chair setting, so we just push a button and put everybody up in a chair, because even if they were feeders, because it really can change the outlook on the day by, as much as we all would love to eat breakfast in bed, it's not normal to eat breakfast like that in bed. So I really think it's really important, and somebody who has a chronic condition like that, it's really important to get them up and get them moving, even if they're just going to a chair. And then making sure they're getting adequate nutrition. So even in long-term facilities, if they're on feedings and things like that, making sure that you make sure there is a dietary consult to make sure they have the adequate calories and things like that. Just because they're on a special diet doesn't mean that we just assume they're getting what they need. Exercise therapy is the cornerstone intervention in the management of individuals with impairments with mobility. Several forms of exercise therapy exist. There's like ambulation exercise therapy, joint mobility, exercise therapy of stretching, exercise therapy as balance. Exercise therapy is performed by nurses and physical therapists in the acute care, community-based, and home care settings. The goal of exercise therapy is rehabilitative or preventive and is often done in multiple combinations. There are many examples of exercise therapy, such as range of motion exercises, water exercise, and gait training. Specific exercise therapy interventions are created on patient needs in collaboration with physicians, nurses, physical therapists, and occupational therapists. I think especially like muscular skeletal conditions is really where you reach out and you really work very closely with the interdisciplinary team. There's also pharmacologic agents, and there's many drugs that are used to treat mobility problems, and they're for relief of pain and inflammation or to even treat the underlying condition. It's beyond the scope of this concept presentation. Obviously, there's anti-inflammatory drugs, there's analgesics and muscle relaxants, and then there's supplements. And supplements, and when we look here, in addition to adequate dietary intake, nutritional supplementation with vitamin D and calcium is useful prevention in treating measure for osteoporosis, particularly for postmenopausal women. We can also look for surgical intervention. So many conditions that affect mobility are treated with surgical intervention. Surgical intervention can either be curative or palliative, depending on the underlying conditions. So examples of surgical interventions related to mobility and immobility include like arthroscopic procedures, maybe some open or closed reduction of a fracture, maybe even amputation, debridement, a spinal fusion. And really it will just depend on like the underlying cause. Immobilization. Following an injury or surgery, immobilization of a joint or bone is often necessary to provide stability and hold the appendage in place so that healing can occur. So following a fracture, for example, bone remodeling takes several weeks before the fracture is stable. So immobilization is necessary to enhance the healing process to protect the bone from further injury and provide comfort to the patient. So these may be like casts, splints, abductor pillows, braces, and traction. So assessment to verify the adequate perfusion, movement, and sensation is critical. Another indication for immobilization is to prevent injury. So for example, for all patients with suspected spinal injury, spinal immobilization is routinely applied in the pre-hospital setting by strapping a patient on a backboard and using a cervical collar to prevent head rotation. And that's done in a preventative setting, like to prevent any further injury, but also until the ER physician can determine if there's actually been a cervical injury or not. So assisted devices and patient handling technology. Assisted devices are objects to provide assistance with a task. So many types of assisted devices are commonly used in patient care, including assisted devices for ambulation and assisted devices for activities of daily living. So common ambulation assisted devices are like canes, crutches, walkers, wheelchairs, prostheses. Patients must be taught how to use these devices correctly, of course, to avoid injury. So they may be set up in PT, like before they go home, PT will come in and like fit them for the crutches or canes and even walkers, and make sure that when they go home safely using these devices. Patient handling technology refers to a variety of equipment in the care environment designed to assist with the handling and movement of patients. These are like your transfer mat, slings, and lifts, and education and training on indications and the use of these devices, including like assessment and decision algorithms for equipment selection, are essential to ensure the safety of the patient and the healthcare providers. Mobility links to numerous concepts. Those considered most important are shown in this figure. Individuals who have inadequate gas exchange may experience reduced mobility because of excessive fatigue. Immobile patients are at risk of developing complications associated with gas exchange, such as statious pneumonia due to reduced lung expansion. The brain controls movement, coordination, and balance. Thus, optimal mobility is dependent on the intact neurologic systems. Individuals who have problems associated with intracranial regulation may become immobile as a result of unsteadiness, imbalance, or the inability to initiate or execute purposeful movement to the arms, legs, or trunk. Individuals who are immobile may be unable to purchase, prepare, or consume adequate nutrition. Likewise, individuals with inadequate nutrition may also have decreased mobility because of excessive fatigue. Malnutrition can lead to muscle wasting and bone loss. In addition, individuals experiencing extended immobility often experience reduced appetite. Pain may interfere with mobility. For example, an individual with chronic pain associated with cancer or back pain may experience changes in mobility as a pain management strategy. Likewise, some conditions that are directly associated with immobility are very painful. Individuals who have impaired perfusion are less able to be mobile because of reduced oxygenated blood reaching peripheral tissues. Among individuals who are immobile, perfusion is less effective because of reduced venous return and because of extended pressure on the tissues. Immobility is a significant risk factor for impaired tissue integrity. Extended pressure on bony prominences reduces the perfusion of oxygenated blood, and skin shearing from movement and transfers may occur, particularly with extended immobility. Individuals who are immobile may have changes to their pattern of elimination or be at risk of experiencing problems with constipation or urinary retention. This often leads to discomfort, reduced appetite that could negatively affect nutritional intake. Question number 1. What population group is at greatest risk for impaired mobility? The answer is 4. Because of the effects of aging, the population group at greatest risk for impaired mobility is older adults. Question number 2. What bone disease may develop in response to immobility? The answer is 3, osteoporosis. The lack of weight bearing leads to bone demineralization and calcium loss from the skeletal system. Over time, osteoporosis can develop in response to immobility. Question 3. What diagnostic test would be used to determine the core mineral content and the density of bone? The answer is 1, bone mineral density. BMD is used for the diagnosis of osteoporosis and osteopenia. This concludes our lecture on Concept 26, mobility. If you have additional questions, please reach out to your instructor.